Hello, everyone. Thank you for joining us and welcome to the 2021 series of RACGP Victoria and DHHS, which I think has lost an H, DHS Victoria webinar series on all things public health. Let's face it, it's all things COVID this year. Just going to allow some people to filter in. So we've got some people joining just in these first few minutes. We'll let some people join before I start formally. But I would like to congratulate you all on making a good choice joining us this evening. There's nothing better on television than this webinar series, I can assure you. So thank you for joining us. And we're going to be tackling a lot of really interesting questions about this vaccine rollout. So I am going to start the webinar now. I'd like to begin by acknowledging the traditional owners of all of the lands on which we meet. I'm on Wurundjeri land in Melbourne and pay my respects to elders past, present and emerging, and my respects to any Aboriginal or Torres Strait Islander person who's listening. We have a really big discussion here, I'm sure, tonight. So what I'd like to remind everyone is to use the Q&A function. That's how you send a question up to myself and the panelists. We will keep an eye on that. We will try and group like questions together. So you may not hear your exact question, but we're trying to get through them as much as we can. If you like somebody else's question, just press the thumbs up and that will draw that question up to the top. And that will also help us not repeat questions unnecessarily. So that's how things are going to run. We will have this recorded and available on the college website. So we have got some really well-known faces in public health in Victoria joining us, I'm really pleased to say. We've got Professor Brett Sutton, who's the Chief Health Officer for Victoria. Dr. Annalise Van Diemen, who's the Deputy Chief Health Officer and who's been speaking to us for nearly a year. Professor Ben Cowie, he is the Executive Director, Senior Medical Advisor of Engagement and Partnership, and working very hard on this immunisation rollout. Ben is an infectious diseases physician. And Associate Professor Nicholas Wood, who is the Associate Director, Clinical Research and Services at the National Centre for Immunisation Research and Surveillance. So we're going to get started momentarily with a presentation just as a brief update of what is going on out there. And we're going to leave sufficient time because I'm sure people have got a lot of questions about what's going to happen starting next week. So I am going to hand over to Brett, who's going to take us through what's going on out there, and then we'll move through the vaccine discussion and Ausvax, and then onto some questions. So thank you very much, Brett.
Thanks, Anita, and thanks very much for the opportunity to come tonight. I'll give a very high-level interview. I'm not the expert here, and I haven't been as engaged at the coalface as Ben in the engagement and communication space, and Annalise on all of the logistics and operational activity, which has been a really monumental task, and there's been months and months of preparation to get to this point. It does look like it's coming to a head, obviously, with arrival of vaccine, the Pfizer vaccine in Australia. The Eagle has landed, and with plans to commence the first vaccinations in about a week's time. But there has been months and months of preparation, and the operational complexity, I think, has been flagged both nationally and within Victoria, but it really is a mammoth logistic exercise and has been called the biggest medical operational exercise, or the most complex that we've seen maybe in our lifetimes, if not longer. So it's a very exciting time. I think we're well placed, but it is also an area in which we're kind of exploring as we go along. We haven't done anything like this previously. You'd all be extremely familiar with the National Immunisation Program, where clearly we've gotten into a rhythm of routine vaccinations. Of course, there are schedule changes, and there have been more and more schedule changes every year as time has gone by. But compared to the complexity of this national campaign approach to a vaccine, the NIP seems very mundane and straightforward by comparison. I think one of the other challenges with this is that we'll have multiple vaccines. We'll have a greater level of community uncertainty and ambivalence with respect to the vaccine. It's happening in the middle of a pandemic, and it's not one with which we have any familiarity. Obviously, we're all incredibly pleased that in 13 short months, we've gone from nothing to 200 candidate vaccines, 200 plus candidate vaccines, with a handful that are already either have gone through a preliminary or emergency use authorization in a number of countries. And there are many more that are in late stages of phase 3 trials or going through a regulatory approval process overseas. So that's all extremely encouraging. But this is a campaign, unlike measles vaccination campaign of recent years or relatively recent years. Again, it's new vaccine and with a Commonwealth-led process for procurement, distribution, and really end-to-end management right up until the point of administration. At that juncture, it's a partnership. I mean, it's a partnership all the way through, but it has unusual features in as much as the Commonwealth has taken on a really significant part that might normally be considered part and parcel of state and territory government operations for a vaccine. No argument with that whatsoever. The Commonwealth has spent billions and billions in doing that, and none of us should get into a space where there's one-upmanship or a sense that we need to shift responsibility. We have a collective responsibility to get this right. It is, as I've said in media in recent days, the beginning of the end of the pandemic, and we really need to see it as something of enormous value for everyone. And we do not want, this will be won or lost in the communication engagement space from my point of view, and the trust and faith in the program will be both around that communication engagement, but also in delivering on what we say we'll deliver on. And so we need those supportive messages and both the sense and the genuine collaboration between Commonwealth and states and territories to make sure that we deliver on that promise and address the challenges of this unusual partnership and a new and emerging and exploratory space for us to deliver it. We've got a Pfizer vaccine that has special storage requirements at below 70 degrees Celsius, really up until the few days around its administration, which will bring its own challenges in terms of the equity in it being provided and the fact that it might look metro-centric in that regard. But also we've got an AstraZeneca vaccine that's had its regulatory approval now. Again, very exciting, and hopefully the real scale up that we might see akin to a flu vaccine given through primary care at a real rate of knots, so that we can get that coverage that we know will make a difference to the transmission dynamics that will turn this around. There are really nuanced and complex questions around when do we let it run, when do we allow that first community transmission of coronavirus to occur in Australia. That's with Phil Gaetjens in Department of Prime Minister and Cabinet and all other secretaries across the country. But it's a privileged and but challenging space to be in, to be effectively COVID-free across Australia, to be able to make these choices. But I'll leave my further words to any of the questions that arise and hand over to the real experts here. Thank you.
Thanks for that introduction, and I agree. I think one of the important things about this, and this has been spoken about a lot, is helping people to understand that there is a divide between federal and state funding and participation in this program, which can be confusing. But more important than that is understanding that the two echelons of government are working very hard together to make the most successful program possible. So I understand that people need to understand the differences between how the two governments are participating. But I think that the most important thing really is just getting down to work and getting people immunised without having, to dive too deep into that politics. I'm going to start. We've got a couple of questions, and I know Annalise is going to jump in and discuss those. But one thing that I feel we've got a great opportunity to clear up for our members and therefore our patients is the perception that I think has been generated by the media that one vaccine is superior to the other, one vaccine is going to do a better job in protecting people, and there is a lack of equity in the community based on who gets what vaccine. I think that is becoming clearer in the last few days with more information about the AstraZeneca vaccine, but it would be great to hear it from the experts, comments about the differences between the vaccines and clearing up those controversies about which will protect us better.
Couldn't agree more.
Sure.
And if I have a last word, it's really to say we do need to challenge that narrative that we've got a fantastic vaccine and a second-rate vaccine. I mean, we've got what we've got, and we need to ensure really substantial coverage for the protection of individuals. But also, the AstraZeneca vaccine will provide a really significant benefit in terms of protection from severe disease. There is a space in which we need to get better and clearer and more robust information, but that will be forthcoming in the next few weeks, really. So we do need to challenge that narrative that it's not worth taking, or that you would hold out on getting a vaccine in order to get the Pfizer vaccine because that's the only one worthwhile. But in that space, we do need to be honest about where there are gaps in understanding, where there might be a difference in efficacy in protection, where there might be differences in the efficacy in reducing transmission, and no spin should occur in this space. We really do need to speak to the weaknesses, the gaps, and the areas that we need to explore further.
Yeah. I don't know. So Anita, I'm happy to chime in here, and I'm sure others will too. But I'm also happy to answer this question. We've got some slides to work through as well. I don't know if you want us to get to the presentations and stuff as well. But just on this issue, because it is a really important one, I know. So while I think that, let's break it down a few ways. First of all, the efficacy statements of 95% versus, pooled analysis 67% between Pfizer and AstraZeneca. As Brett's saying, clearly that's for symptomatic disease, and there's a lot less difference when we're looking at serious illness requiring hospitalisation or mortality. And also picking up on what Brett said, we don't know the evidence on blocking transmission or asymptomatic infection. That's still to come. And so there is more work to be done. One really important point that I think is being lost a little bit when we look at this is the difference between the dosing frequency, particularly for AstraZeneca, the spacing between the two doses. Because in that analysis, in the preprint or the early view from the Lancet on the 1st of Feb, I think it was, from the AstraZeneca vaccine, if those doses were spaced by 12 plus weeks, the efficacy against symptomatic infection was 82%, okay? Versus if they were spaced by less than 6 weeks, it was 55%. Now, clearly, there were differences between the populations. The AstraZeneca trial has been contested and recontested in all sorts of fora. But this is why, when the TGA have listed this 2 days ago, or yesterday actually, they've said, the 4 to 12 week spacing between doses, but furthermore, the ATAGI have come out saying that spacing by 12 weeks is preferable, and that's reflecting this difference. So I think that's another narrative that we need to get into circulation, is that by spacing it out, the efficacy looks like it's substantially improved.
I think that's such an important point. And what we will do, I agree, Ben, let's go through some of these slides, because we may well start answering these questions by default, and those which are left at the end of your presentation we'll go through. So
sure,
if you wouldn't mind.
Yeah, of course. So I think Brett was going to speak to some of the epi updates. I don't know if you're wanting to work through these slides briefly, Brett.
Sure, I haven't seen them, but I can do it on the run.
Yep.
That's our first and second wave, a 68-day period of 0 cases. We had no hotel quarantine program and no community transmission. Then some cases that have arisen in hotel quarantine, a couple of clusters to deal with, one arising out of hotel quarantine in New South Wales, and really one that we're right in the middle of now, arising from hotel quarantine with a variant of concern, but effectively driving down those numbers to 0 again. So in a good place with 25 active cases currently. So we've taken some pretty substantial actions over the last 5 days. They've been lifted as of midnight tonight. So the stay-at-home directions that have been in place were really to minimise the opportunities for all of those individuals who've been potentially exposed across 40+ exposure sites, the 3,400 primary close contacts and almost 10,000 total contacts. The lockdown, if you like, was to make sure that if we saw 1 or 10 or 100 cases arise in those people at exposure sites, that they wouldn't themselves have 20, 30, 40 close contacts. We're very happy that we've wrapped the public health response around that, and we're going back to more or less COVID summer safe restrictions, other than private gathering limits, household limits, and some public events have been pared back as well. Next slide. Those are our current restrictions. The main difference is that it is only 5 people to your home across the state, outdoor gatherings at 20, face masks indoors and outdoors. These are things that are not terrible constraints for just another 9 days, which is what we're hoping for. And all the rest is really, hopefully, opening up retail, industry, work in ways that we've been used to in recent months. Next slide. So is this for me? So how do we identify COVID-19? Really, we need a robust surveillance program that's looking for clinical disease. Sometimes we look for people at high risk who are asymptomatic, so those who are known close contacts or known contacts at tier 1 exposure sites, so those exposure sites that we regard as concerning enough that people need to quarantine for a 14-day period. What we know is that people are infectious 1 to 2 days before symptoms begin, and really most infectious in the first few days after symptoms, and that the incubation period is 14 days, but most people develop symptomatic illness 5 to 6 days after exposure and infection. We need to make sure that people who get infection do get tested, and we've had 40,000 tests today, so we're doing really well in that space, but it's a long year to have that message out there, and we need to find new and creative ways to keep that motivation up, but we're doing a pretty good job, I think.
I think absolutely. I wonder if my panelists and the audience don't mind being comfortable with that epi, if we could begin a discussion about the vaccines themselves, and that will give us some time to tease out the rollout process.
Great, thanks. So if we could go to the next slide, please, that'd be great. Unless you want me to run those. Okay, I can share my screen. Here we go. Thanks, Con. Okay, next slide, please. Great, thank you. And that's fantastic. So thanks very much for the opportunity to speak, colleagues. And I think, look, the messages that Brett's just been going through, we need to continue to reinforce those with our patients. Honestly, we can't, just because of the advent of the vaccine, it's not a silver bullet, it's not the end of the story. It's a big part of this final chapter, hopefully, of the COVID-19 story in Australia and globally. But we need to continue to remind our patients that they need to be COVID safe, and that testing, even after vaccination, if they've got symptoms consistent with COVID-19, is really important. So this vaccination program, which kicks off next Monday with the first doses administered in Victoria, it's the Commonwealth program. So as Brett said, this is very clearly the Commonwealth purchasing the vaccines and distributing them to the states and territories. But here in Victoria, we want to implement this program in a way that essentially makes vaccination as easy and available and accessible for every Victorian. The vaccines are free. They will be made available as geographically distributed and representative of the Victorian population as is possible. And general practice clearly has a huge part to play there. Highest levels of safety and quality are really essential. Although this is happening very fast and we're rolling out what, as Brett said, has been described as the largest logistic exercise since World War II, we have to do it in a way that is respectfully partnering with all groups, and that includes general practice and other primary care settings, and is respectful of the community and their choices. And that's the way we'll build public trust and confidence. And it's really essential. There's a lot of queries, there's a lot of conspiracies, there's a lot of anti-scientific thinking, which we need to, yes, be engaged with, but do it again in a way that's not driving people further away. Next slide, please. So, as I've mentioned, this is a Commonwealth program, but there are clear roles and responsibilities which are shared. Ultimately, the Victorian people will look at this and say, this was the program that was delivered for us, and they won't think about where something went wrong or where something went right. They want to know how to get vaccinated, and they want to know how the system's going to look after them in so doing. And we've all got a role to play there. Next slide, please. So this is the rollout, and I think some questions will come up in the panel about the different priority phases, etc. One really critical point: phase 1A does not mean Pfizer, and phase 1B and the rest do not mean AstraZeneca. Pfizer is starting in 1A because we're getting the vaccine first. We're going to have Pfizer from the 22nd of Feb, next Monday. AstraZeneca, the best intelligence we've got so far, and as we said, it was approved yesterday by the TGA, but it won't be available until March. And we're here maybe early March, which is fantastic. But that's why 1A is starting with Pfizer, not because they're different from the rest of the population. They're just the people at greatest risk. Once we actually have a substantial proportion, as many of the 1A phase as possible vaccinated, we will then move through into phase 1B, 2A, 2B. And I'm not going to prosecute exactly who's in where. That's all on the slide there, and we can talk about it in the Q&A. I guess one really important point for 1A is that includes frontline healthcare workers, and they're particularly in the Commonwealth, and these criteria have been agreed at a national level. This is a Commonwealth prioritisation. Include, sure, emergency department workers, intensive care, but it also includes ambulance staff and paramedics. And the Commonwealth has specified healthcare workers working in GP respiratory clinics and COVID-19 testing facilities. So that's the healthcare part of the 1A workforce. And I think we go through this in a little bit greater detail on the next slide. So we might go forward if that's okay.
Can I just interrupt you, Ben, just quickly? Does it also include GPs working in aged care facilities, the 1A?
So 1A, what the Commonwealth have said is, and that's actually on this on the next slide as well, but we'll keep on this slide for a moment. But to answer your question, Anita, the Commonwealth has said that it's all staff involved in residential aged care facilities. And so certainly our interpretation of that and the way that we're going to be implementing that in the public clinics, the state-run clinics, is that any staff, including visiting staff, general practitioners, allied health, etc., are in scope for providing vaccination in the 1A cohort. The Commonwealth will be running that program in the private sector. I imagine they'll take the same interpretation.
Thank you.
So, yeah, you're welcome. So these are the 1A groups. And as we've said, the healthcare workers are spelled out there in a little bit more detail. Initially, this will all be run through the hubs, and I'll come back to the hospital vaccination hubs in a moment. There is some outreach from those hubs. Look, I think we all recognise after the events in Victoria in the last week, the 1A of the 1A for all of us is hotel quarantine and ports of entry workers. That's the way that we protect not just other healthcare workers, aged care residents, but actually everyone in Victoria. And so making sure those hotel quarantine and port of entry workers are right at the front of the queue and we vaccinate as many as we possibly can as early as we can is such a critical public health imperative. Next slide, please. So this is picking up the point there, Anita, about the public sector residential aged care and disability care workers. So the Commonwealth is looking after private residential aged care, as I mentioned, and the Commonwealth has taken responsibility for all disability care residents and workers. Next slide, please. So this is about the hospital hubs. So they're aligned with Victoria's new local public health units. So specifically the health services that host those. So Western Health, Austin Health and Monash Health here in Melbourne. And then when we go around the rest of Victoria, Barwon, Goulburn Valley, Latrobe, Bendigo, Ballarat, and Albury-Wodonga Health. That's where the hubs are located. Certainly, there is outreach from those hubs. And for instance, the Alfred Hospital, in partnership with Monash, are rolling out the vaccination inside the hotel quarantine program. Western Health are providing a clinic at the airport in the red arrival zone for those workers in the first instance. So through the hubs, plus some outreach for 1A priority workers from next Monday. I guess the really other important point here, and I think this is my penultimate slide or close to it. The other really important point is that the AstraZeneca vaccine, because it doesn't have to be stored at -70, and we're getting 5 times the doses, we're getting 50 million doses, which is 5 times what we're getting in the initial Pfizer allocation in the first half of 2021. That is the vaccine that the vast majority of Victorians will get, including healthcare workers. It is also a vaccine that, because it can be kept in conventional cold chain, that's why it unlocks general practice, pharmacy, community health centres, Aboriginal community controlled health organisations, local council, and potentially some other innovative models such as stand-up testing sites, vaccination sites. I'm going back into testing mode, mobile vaccination, and indeed high throughput vaccination centres. So really, there's the capacity to build an incredibly responsive and flexible model for the AstraZeneca vaccine, at which general practice will clearly be the heart. Next slide, please. Great. So I think this is my last slide, and Annalise has done a lot of work here, and I'm sure that she'll be able to take some questions on this in the Q&A. The authorisation of additional workforce is absolutely critical. Our existing fantastic immunisation workforce are just not able to vaccinate every eligible Victorian over the course of this year. So that authorisation is underway, and there's been a lot of work done there. There's also been a lot of work done in the training space. And again, Annalise's team has developed a training package here for Victoria, as well as the Commonwealth training package, which has been released. And I'm sure Annalise would be happy to take further questions about either of those aspects going forward. But essentially, I believe we're going to talk now. Nick's going to take us through some safety elements, and looking forward to the Q&A. This is a really exciting time. It's a really positive development and something we can all be proud of working together to achieve. Thank you.
Thanks, Ben. There was a lot of information there, answering a lot of questions. You will have seen me ticking questions off.
Right.
If you do want to ask a question, please use the Q&A. We're now going to go to Nick, who is going to, Associate Professor Nick Wood, I should say, who's going to speak to us about the AusVax, and then we're going to open things up for questions. Thanks.
Great, thanks very much. So we won't, given the interest of time and the need for questions, I'll just go through these slides and you can have a look at them later on, but maybe you can just cut through them if you want to the last. This is really the one that's probably the most critical. AusVax Safety is a Commonwealth funded initiative. It's been in activity for several years now. One of the things they do is actively monitor for vaccine reactions. It has been doing that for the NIP program for a few years. And it uses a tool called SmartVax to sit in the back of GP software, such as Medical Director and Best Practice, and automatically send an SMS or an email at a determined time point to vaccinated people and ask them to fill out a survey on their phones. All that data is then collected and sent back to NCRS, where it's analysed. A lot of the de-identified data is also sent to Telethon Kids Institute for the signal detection. And so we've been doing this for flu vaccine last year, and nearly over 300,000 vaccine records were looked at. It'll be done again for flu and most importantly for COVID. As mentioned, there's a separate system that's in use for the phase 1A, which you might want to talk about, but for the phase 1B and phase 2, when the vaccines are given in the GP environment, it's a chance for GPs to install this SmartVax system into their practice software and be able to take part in the safety surveillance. I think there's just maybe one more slide. That's just a description of how it works, which I've talked about. And next slide, this is the sites around the country. That's the story about the flu. in much more detail, which we don't need to go into. And I think the last slide is probably the most important one. That's what the survey looks like on your phone. The surveys can be flagged for serious reactions, and GPs can be told that their particular patient did seek advice from a health care professional or a doctor or went to GP, or they can be flagged for other things like these allergic type reactions. Many states and territories are going to be centrally following these up. In Victoria, there is SafeVic to go to for support. In other states, the GPs will be reported, be given information about the reaction of their patients, and then have the capacity to report that into SafeVic. I think the last slide is just there's a QR code there where you can register your interest to take part in this system. So in the interest of time, I'll very rapid fire throw through the AusVac safety system, which uses SmartVax as one of the tools. And will be hopefully, the plan is to report in near real time via the TGA as the Pfizer vaccine rolls out in the 1A. And then as AstraZeneca starts to get used in 1B and phase 2. So I'll stop there.
Thanks so much. And team, I apologise for what I'm about to do to you, because it's going to be rapid fire sort of question time now, because there's a lot to get through. Just to follow on from Nick's presentation about reporting adverse effects, one of the concerns is, and this was sent to me today from James Way, apparently there's legislation that means that we have to report every type of possible vaccine side effect, both to the TGA and also to state authorities. And so there's a concern about the huge volume there. Questions is that true? And then, what are the mechanisms for patients self-reporting to take the onus off GPs?
Nick, did you want to take that, or I'm happy to take that? It's Annalise here.
Well, I mean, you want to, Annalise, we can, sort of, the active system, we'll be reporting, those data back to Vic Health. For the passive system, you might want to just talk about what you want to have reported through to SafeVic.
Yeah, so look, I'm not aware of any legislative requirements to report all and any types of adverse event following immunisation, and absolutely that. So we'll follow that up with the Commonwealth tomorrow, but we're in meetings with them like 3 times a day, and there's been no legislative requirement discussed at all on that front. So I can pretty confidently put that to bed as not the case. Certainly, we will be encouraging that significant events and medically attended events are reported through SafeVic, which is the existing process. There is a few ways in which to do that. Obviously, there's an online reporting mechanism for that, and that's probably the easiest way, because you can just log in, put the report in, someone from SafeVic will contact you if there needs to be an investigation, or if it's sort of a reasonably straightforward thing that's already all sorted. Very much will depend on the event. In terms of sort of the routine sort of minor, I got a sore arm, got the expected fever, bit of a myalgia, feeling a bit of a headache for 24 hours, certainly would not be expecting that all of those are reported into SafeVic, and that is absolutely the point of this active surveillance system that Nick and the team are managing at national level, that we get high level de-identified aggregate data to get a really good idea of what the overarching level of those events are. But absolutely the impost of individually reporting all of those very expected events is definitely not worth it, and that's why this system's in place. But I'll take that on notice and get back to you with a really clear answer about the legislation, but pretty confident the case is no. And
I think once again there's confusion with mixed messages, things happening so fast. There is a legislative requirement to upload to AIR or AIR. There is a penalty of $6,000, but it's not a penalty for reporting side effects, 2 different things. I am going to move on now. We had a question very early on about the use of vaccines in the over 65s, and there's been some confusion. Annalise, I think you're going to help us with that.
Sure, and apologies, I should not try and do Q&As when I'm on my phone. I thought I could type an answer. Didn't realise that I'd accidentally volunteered, but nonetheless, we all noted that TGA line in the approval, and there's a lot of work going on in the background to clarify. That is my understanding, particularly at a TARGI level. The clear, and so that will be, I hope, clarified very shortly in the next couple of days. But the clear messaging that we're getting is that it is intended, the intent is that it is registered for over 18s in general, and that I'm not quite sure what that line from a regulatory perspective was intended to portray, so I won't put words in the mouth of the TGA, but it's been noted sort of far and wide, and hopefully there'll be a lot more clarity in the next few days around how to manage those patients. My understanding is the intent that it is intended to be available for those patients.
Okay, I'm going to ask, the immunocompromised patients is coming up a lot. Can one of the team tell us, what concerns GPs have to have about vaccinating immunocompromised patients, and is one vaccine or another preferable or to be avoided in the immunocompromised?
I can take that on if you like.
Please.
Yep, sure. So look, certainly no specific safety concerns with either of the vaccines with immunocompromised individuals. Clearly, people with reduced immunity will have lower degrees of efficacy from a whole range of vaccines. Clearly, their immune system doesn't respond to antigens the way other people's do. So the efficacy question is certainly potentially open. There has been some people, for instance, with HIV included in latter aspects of clinical trials of the Pfizer vaccine. The AstraZeneca vaccine was trialled in HIV positive individuals, particularly in Africa. There was a reduced efficacy noted amongst those individuals. It should be noted again. No particular concerns around mRNA vaccines and immunodeficiency. So on this basis, ATAGI have recommended that COVID-19 vaccine is recommended for people who are immunocompromised. And that's particularly because they're at greater risk of severe COVID disease as well.
Mm. Yeah. So thanks, Ben. Sticking with the vaccine specifics at the moment, is there much point in using the AstraZeneca vaccine, for example, if we think that new mutant strains may not, it may not offer much protection?
Again, I can start with that one unless anyone particularly wants to jump in here. Okay, so look, these emerging variants of concern are very aptly named. They're concerning. The evidence from, certainly, for instance, in South Africa with the emerging variants of concern, is that there is breakthrough infections with natural immunity. There is a significant proportion of those people being infected with those variants who have already had documented COVID infection. So it is not surprising if these variants can break through naturally acquired immunity from infection, that there will also be an issue with vaccine-derived immunity and them being able to break through that. So is it likely that we'll need to tweak vaccines going forward and to ensure that they cover emergent variants that are escaping from the very selection pressure that we are imposing on the virus? Yes. Is it also the case that having these vaccines on board has efficacy against a range of variants? Yes, absolutely. And finally, if we're looking at the privileged position that Australia's in now, by having a highly immunised population, we actually reduce the chance of transmission of variants and therefore the genetic potential for them to acquire mutations that lead to evading from immune selection pressure. So the best way to prevent the emergence of those variants here is preventing the transmission of COVID, including through vaccination.
Thanks, Ben. I agree. And look, we do that, I guess, in some ways with the flu vax. We change based on its mutation.
Every single year.
Yeah. So a couple of logistical questions. If we've got somebody who's in 1A, how do they get their vaccine? Do they call up a hub? Does a hub call them? Does the vaccine go to a nursing home? Does the nursing home resident go to the vaccine? Can you give us some of the logistics of what will actually happen on Monday?
Sure. Annalise, do you want to take that one or shall I?
Not fast. Happy for you to if you want to start.
Why don't you start off? I've been talking too much. You go first.
Sure. Anita, so there's a range of ways that people are making their way into the system. Aged care facilities particularly will be accessed via outreach teams, and that's happening in the most part via the Commonwealth contracted groups, but equally there's some state outreach happening into our public sector residential aged care facilities. As Ben mentioned, as much as possible, those really high risk workers at the border, in the red zone and in the hotel quarantine, we are trying to vaccinate on site to get through them as quickly as we can, but to also minimise the need for them to walk into a health service given the risk of their work. And then for the most part, then the next phases of getting people into the hubs are happening by invitation. So those first cohorts are being invited by their workplaces into the hubs, and pretty soon in the next few weeks we will be looking at getting sort of the next rounds of the 1A groups into those hubs to get their vaccines as well. So yeah, 1A in the first part is really invitation based, but then as soon as we get larger amounts of AstraZeneca vaccine, it will be looking at becoming a much more sort of open mechanism, particularly as soon as that vaccine gets into general practices and we can start doing those 1B populations who are really important in the community.
Thank you. I'm about to hand over to Marina, who's going to continue a very informative session. My last question to whomever feels up to it: what is a GP going to say in a few dot points to patients who are vaccine hesitant that we have some opportunity to convince to actually go ahead with the vaccine?
Okay, I can start with, Brett, did you want to chime in there?
To say very quickly, honesty, openness, establish that rapport that you will have with your patients, and speak to your own motivations for getting the vaccine. We all know that it is part of the solution to not having to have these damn circuit breaking lockdowns or rolling lockdowns, or the threat of a third wave or a fourth wave or whatever it might be. I think that's a real motivation for a lot of people, but you need to address the ambivalence that they have about the fact that this is a vaccine that's been developed over 12 months rather than 10 years, that there is more social media misinformation than at any other time in history, and that you need to raise with them what their specific concerns are and try and talk them through each and every one systematically. I think there'll be a small proportion of people who are definitively anti-vax, conspiracy theorists, etc. There'll be about a quarter of your patients who have some ambivalence that is not illegitimate, but that will be very much influenced by the trust and rapport they have with you as professionals.
Yeah, look, absolutely important principles. And I think, again, as Brett said, sort of explaining why you, as their GP, are getting vaccinated and why you'd like to vaccinate your family and loved ones. But the core messages, I think, are these vaccines are safe. They've been studied rigorously in tens of thousands of volunteers in international trials. They've been administered to tens of millions of people overseas already. And whilst we're awaiting on firm data, certainly in those countries, we're seeing significant reductions in COVID-19 transmission in countries which have imposed these vaccine programs, although the attributable part of that, I wouldn't say this to a patient, but to you, I'm saying the attributable part is to be determined, that they are hugely effective at preventing serious illness, the need to go to hospital and dying. And the emerging evidence is they are a big part of reducing transmission in the community, which will keep us all safe and keep Victoria open.
That sounds amazing. That's what we need to all say right in the middle of our consult when we're seeing people for other things and it's coming up. I think that we definitely think that honesty, communication, openness, and engaging that's our role. That's what we do. We would love like a one-stop shop that gives us all of this robust information and all of the hiccups that we're going to come up against, like why one vaccine, not another, why they're both good, what are the side effects and how often are they, what are your worries, these are a good response to that. That kind of thing would be just incredibly useful in general practice. We've found that we've had to sort of scurry around to find info, and we're drawing it from lots of places. So I think, you know, to tackle the people that are not sure, that would be really a really good idea. Just talking through the logistics a little bit more for us, you know, so I had my 84-year-old patient during the week who said, so when will you let me know when I'm going to come in for my vaccine? And I said to her, oh, well, you won't be getting it from us, but so will you will contact the elderly? How is that going to work? How are they going to know where to go and how to come in?
I can take that one if you like.
Sorry, go for it, please. Go on for it, Annalise.
So certainly we're contacting 1A patients through their employers, and nursing homes will be contacted, you know, as the rollout happens. But the community, no, we don't have a sort of database of older people or people with comorbid conditions. So certainly would be really encouraging practices to utilise their systems, or practices who are signed up to who end up being successful on the EOI front to utilise their practices software, etc., to get their patients in, noting then there will possibly be a gap if there are practices who don't become vaccinating practices, and how we manage their the collective we manage their patients to try and really get the best opportunities for people to come in. And there'll be a combination of media, mostly driven out of the Commonwealth, but we're also aiming and working really closely with the Commonwealth to make sure that there's as many as clear sort of no wrong door policies to get people into appointments within their communities if their immediate existing primary care provider isn't able to provide that. And I suspect there's probably going to be a few more things coming out of the Commonwealth in the next little while on that front as well. But Ben, did you have anything else to add? Oh, while I've got the floor, can I just check, Marina, that you're aware of the MVEC website? A lot of the things that you discussed just at the beginning then are on that website. They've done a fabulous little video about the vaccine journey that explains a lot of those concerns people have about the rapidity of the vaccine development really nicely too.
Yeah. And is that for patients, for us to direct to patients?
So there's a lot of provider resources on there as well. It's actually, for the most part, aimed at providers to give you information to help you manage your patients.
Yeah, but Marina, there definitely is. So we're building out the Department of Health COVID-19 vaccine website. This is a Commonwealth program, and so there's been sensitivities and sort of ensuring that we're coherent with the Commonwealth message as good sort of federal citizens that we all are. However, we perceive, and we've heard very much, the need to have a central repository of Q&A, for instance, both for clinicians and the kind of stuff that you'll be asked by your patients for Victorian clinicians. And so we're in the process of building that out. Should be available really soon, actually.
Excellent. That's what we wanted to hear. I'm not even sure, Annalise, if you can, maybe it's too many steps away, but I also have had questions from patients that have got medical conditions, and they're like, well, do I have to prove I have a medical condition if my GP practice isn't a provider and I'm going into a hub? Do I need a letter? Like, how is that going to work?
I think that is honestly something that's still being worked through. I've heard mention of, perhaps someone's, insulin script might be enough, or a letter from their doctor. And so I'm certain we don't have an absolute answer for that at the moment. Again, obviously, if they're using their existing primary care provider, and that's why primary care is, crucially important in this, because that's where people, the doctors and the carers know their patients and know their preconditions and have that existing relationship. But certainly there is a need for further work on how we can ensure that people who are eligible don't have to jump through hoops to get a vaccine. And that's really the aim of this.
Yeah, and I guess My Health Record is another opportunity as well.
Annalise, I just wanted to talk to you about increasing your vaccination workforce. There will be a lot of GP practices that don't meet the physical criteria for an EOI, and also have done sort of the business models and can't actually afford to give their patients the vaccine. So you will have a workforce that is very trained in giving vaccines. And is there a capacity for GPs to be part of the DHHS's involvement?
Yes, absolutely there is. And not sure how much awareness there is of this process to date, but during the second wave, a process was set up through the department, partnering with Torrens Health as a sort of a surge workforce, centralised single point of surge workforce. But this isn't just surge by the normal sort of definition of we need someone to cover the PM shift tomorrow. This sort of service provides people for direct employment for 3 months, 6 months, 12 months, or that more ad hoc, or we need someone to cover a couple of weeks here, or we need someone to cover a shift tomorrow. So there's quite a breadth of the mechanisms of surge that are being covered there, and there's an EOI process that's happening at the moment, and I believe we'll be providing that, or have potentially already provided that through to RACGP to send out to members if they wish to register on that front. Now, obviously, there's only sort of 4 hubs up and running for next week, or a couple of hubs up and running for next week. That is going to expand pretty rapidly over the next little while, and there'll be all sorts of different opportunities in different areas of the state. So that would be the first step, really. And then the second step, for people who are interested, I'd really encourage you to undertake the Commonwealth training package that's already up and available for all providers, and for general practitioners and existing nurse immunisers, that is sufficient. Although there is also a secondary package that's on the MVEC website that has some really lovely videos and that kind of thing. If people, particularly a new video on multi-dose vials that people could look at if they're interested on that one as well.
There's also a few questions about our patients that really don't manage digital media or technology very well. Lots of us have got those patients. And then you've also got the quite marginalised and homeless. How are they going to go without having sort of that digital technology to know what to do, where to go, how to follow up, all of those things?
Ben, did you want to take this one, or did you want me to cover this one too?
I can start. So certainly all the way through the vaccination journey, where and this is again something we learned last year, obviously, is that not everybody has access to smartphones, and not everybody is able to or seeks information from online resources in the same way that others do. So all the way through from initial education, we're using other fora, so spoken, going out and speaking to communities. We're doing a lot of community presentations and engagement, resourcing their trusted community members, both medical and otherwise, faith leaders, community leaders, giving them trusted information that they're then translating into local resources. WhatsApp groups, that WhatsApp groups been established for community leaders to then translate authorised or evidence-based messages out into their communities. In terms of the actual vaccination journey itself, for instance, people aren't going to obligatorily have to use, for instance, a smartphone for their booking system or emails, and even the vaccination certificate in some circumstances will be able to be printed up if there's the facility at the site where the vaccination is occurring, or it's on their Australian Immunisation Register and it's uploaded for them, not requiring them to be tech literate. So all the way from the initial information right through to the certificate of vaccination, there are analogue options, if you will, for patients to be able to engage with.
Thanks, Ben. One of the, we're so excited about this first vaccine. I've got my sleeve rolled up already, but you've got to have 2 for really to get antibodies that are going to do the job. Can you tell us about the recall process? Who's going to do that? Is that going to fall to GPs and individual practices? Is it going to fall to the booking system? And how are we going to make sure people get that second vaccine and get the right one?
Do you want to do that one, Annalise? Or?
Yeah, sure. So there'll be a few mechanisms for recall. Obviously, there's the standard recall mechanisms that all of your practices would have. Anybody that which we would absolutely be anticipating goes through that. There will be recalls being generated through AIR. So people who've got sort of your MyGov app for those who are parents would have it. So that get those joyful daycare reminders that you might have forgotten your kids' 4-year-old vaccinations. Anybody who goes through the state clinics will get recalls through that booking system. And one of the analogue options that we're also working up this week is a little card that will have people's first date on it and a you need your second date vaccine at a 3-week interval for the Pfizer Comirnaty vaccine or the 12-week interval for the AstraZeneca Oxford AstraZeneca vaccine. So there's a few mechanisms, and personally, I'm going with the thing that I'd rather somebody get 3 recalls and it annoy the living daylights out of them than they get none. Like Ben said, though, that single source of truth will be the AIR, and certainly there's a lot of work going on in the background to try and ensure that we can utilise what is in the AIR and work with as many partners as necessary to try and bring people in for those second vaccines. And that's the kind of work that already occurs with all of you and with local government and with others for children who are sort of, behind in second and third doses of their childhood vaccines. So it will be a real expansion of that kind of work to try and, find those people who might have not quite got around to the second dose vaccine.
How would we handle vaccinating a patient who doesn't give consent for us to upload to AIR? As GPs, can we upload that because that is now a legislative requirement?
That is a really good question. And I might need to take that one on notice because it's not really something that we've come across much, because generally people want things on AIR because it means they get their family tax benefit payments and their childcare rebate. So there hasn't often been objection to the AIR, it's just objection to the vaccine in general. So can I take that on notice and come back to you about AIR refusal? Thanks.
Yeah, it's a really good question. And clearly there are precedents with things like notifiable disease legislation, which overrides privacy legislation and consent. Also one for the MDOs, perhaps. I wonder if the medical defence organisations have a perspective on that one.
Yeah, it's certainly worth us following up, and we will take that on notice. We've got just 2 very short minutes. If somebody could give me their spiel, if I was to say to you, but didn't a whole heap of people in Norway die with this vaccine, what would you say to me?
What I would say is a significant number of very frail patients in those nursing homes did die. And sadly and tragically, that is what happens to very frail elderly people, is that they've got an excess mortality, and that the review by the Norwegian authorities, as endorsed by European investigators, and indeed the TGA were closely in touch with those, found that there was no excess mortality attributable to the vaccine amongst those cohort of people. So tragic, yes. Sad loss of life, yes. But following vaccination doesn't mean caused by vaccination.
Yeah, there's a difference between an association and causation, isn't there, Annalise?
Yeah, and to follow up on Ben's point, I think that is a really good point to prepare ourselves for, because the reality is, if we are vaccinating almost all of the adult population, there is going to be a number of them for whom something will happen, be that death, a heart attack, a stroke, or something else that was probably always going to happen, but that happens in the vicinity of the time that they have their vaccine. But we are absolutely committed through SafeVic, through our connections with TGA and others, that all of those things be investigated. And there will be a period of time for all of those where they are under investigation, and where we won't necessarily be able to say, yes, it was, or it was not attributable to those vaccines, and there are some for which we will never be able to say a definitive. So it's likely that there's when these kinds of things happens, there's 3 possible outcomes, which is really difficult to communicate. One, it will be really clear from the baseline mortality, and we've got, you know, on the epi team at SafeVic are already building up that data for us so we can rapidly compare these kinds of things. But they will review that and say, no, this is an expected level of X condition or mortality in this age group over this time. It's quite possible that they might say this 1 or 2 people who had this rare condition about the same time, we're just not sure, and then it's possible that a signal does emerge and that something does come out, and that we really must be extremely forthcoming and open about that as early as we possibly can.
Yeah, that truth and transparency is really important, but I can't think of any better people to deal with clinical uncertainty than GPs. You do it every day. You're talking to your patients every day about the balance between probability and risk benefit, and, you know, what caused what. I mean, in terms of translating science in a way people understand, GPs are the champions of that.
Ben, we are, and I'm glad that you know that. And I remember in a conversation with you, you said, GPs have the hardest job in medicine. I wouldn't want to do it. And
I didn't say that last bit. I said that's the hardest job in medicine. Didn't say I wouldn't want to do it.
Well, but you did say it was the hardest job in medicine. I remember this bit.
Did.
I'm like, he doesn't want to do that. And I don't blame you, because it is hard. But thank you for acknowledging. And as I say, most webinars, everyone knows it will be general practice that saves the world in the end. So thank you. We're about to end. When Con presses end meeting, everyone just disappears. It's a bit abrupt and rude. I want to thank everyone for joining. I know everyone is working incredibly hard and they're very, very tired at DHHS. So thank you for your time. We are going to be running more than just one monthly webinar while the vaccine rollout is occurring. So there will be additional webinars to support the vaccine rollout. We will keep you updated when they are. I'm really looking forward to talking to these panelists more. It was a great discussion. Thank you for supporting us. And we will see you in a fortnight's time this time.
Thanks, Anita.
Thank you.